I am Dr. Vasudha, and we would be discussing the research advancements in this year, the year that passed by, 2023. So basically, the next 15 minutes, I would divide my talk into stroke, acute ischemic stroke, ICH, FAH, and then finally TBI, talking about the recent publications that happened that may be practice changing for us in the coming few years. So let us just start with acute ischemic stroke first. So the first things first, see, stroke was considered a pretty morbid disease in the past, but there was a groundbreaking revolution with the invention of alteplase way back in 1996 when the NINS trial came. And, it became a standard of care to give IV RTPA to all patients who presented in the time window of up to 4.5 hours. Then came the era of tenecteplase, and we've been having a lot of studies on tenecteplase recently. The reason being that it is cost effective, the reason being that it can be given as an IV bolus, it is more fibrin specific, and lots of advantages with tenecteplase. Now, in the early 2020s, we had a large trial from the Canadian doctors, and that was the ACT trial. It was a huge one, around 1,500 patients, and they proved that tenecteplase was non-inferior to alteplase in the treatment of acute ischemic stroke when given in the given time window. In 2023, this idea was reiterated by another trial which came up in the Lancet, and that was a TRACE-2 trial. So it said tenecteplase versus alteplase, doses used was 0.25 milligrams per kg for tenecteplase, up to a maximum of 25 milligrams. And what they did was, this was a Chinese study, basically multicentric, involving around more than 1,400 patients, prospective open label blinded endpoint, randomized controlled non-inferiority trial, and the patients were randomized to receive either tenecteplase or alteplase, and they found that tenecteplase was non-inferior to alteplase. So combined with that, along with ACT from Canada, the TRACE-2 from China, and we also had the NORTES, a Norwegian trial, basically. Evidence is building up in favor of using tenecteplase as single IV bolus to all the patients who come to us within the recommended time window. We'll have a discussion on this later during our panel discussions. If I want to admit, 2023 was basically the year of advances in endovascular therapy. Till now, the indication for mechanical thrombectomy in acute ischemic stroke was an MRS of around of less than 2, and aspects than 6, and NIHSS of more than 6. But now what happened in late 2022 was a Rescue Japan Limit trial, which came up and which said that you can perform mechanical thrombectomy in patients who have a large ischemic core as well. But the problem was that this study, which was published in April 2022, they just included patients up to 6 hours of last known well. So they said that patients with large ischemic cores, the aspects being 3 to 5, had better functional outcomes with EVT than with medical care alone. Now, 2023 saw 3 major trials of performing a mechanical thrombectomy in a large ischemic core. So this was the ANGEL aspect. This was a large Chinese study that was published in NEJM in 2023, multicentric, acute anterior large vessel occlusions with aspects 3 to 5. So almost a moderate kind of a stroke with a core volume of 70 to 100 ml. And the time window was also extended to up to 24 hours of the last seen normal. And the enrollment was 456 patients, and they concluded that there were better outcomes with EVT compared to medical management alone. However, they also found that there was a greater incidence of symptomatic ICH in the patients who underwent EVT in a large ischemic core, so 6.1% against 2.7%. Now, following the ANGEL aspect came the SELECT-2 trial. Now, this SELECT-2 trial also came around the same time, April 2023 in NEJM, university, multicentric, across North America, Europe, Australia, New Zealand, involving almost all the continents. And inclusion was almost the same, aspects 3 to 5. The core threshold was more than 50 ml and presenting within 24 hours. They also showed an EVT benefit associated with better outcomes than medical therapy alone, but they said that EVT was associated with procedural vascular complications. So this was a SELECT-2. And finally, there was a TESLA trial to demonstrate safety and efficacy of EVT in large volume infarcts. But the difference was they were assessing the core with the help of just a non-contrast CT head. So they were not using any sophisticated imaging studies like MRIs or perfusion studies or anything of that sort to use earlier trials. They just used the aspect score. Actually, it was an E aspect derived by a software from NCCT alone. So the inclusion was anterior circulation, large vessel occlusion, up to 24 hours as aspects 2 to 5 on the basis of NCCT head alone. There were 300 patients across 44 centers in US. And even they said that the benefit was much better in the thrombectomy arm as compared to medical therapy alone. And they also found that there was no significant difference in 90-day mortality or symptomatic ICH. Now, on the basis of all these 4 trials, there was a meta-analysis that was published in Interventional Neuroradiology by Kobisi H. And what did they conclude? The EVT conferred a greater clinical benefit as compared to medical therapy for large core infarcts, and the rate of symptomatic ICH was greater in the EVT group. So we would have a discussion on this as well in our panel henceforth, whether doing an endovascular thrombectomy in large core infarcts is the way forward or not. Coming next on to the hemodynamic management after endovascular therapy. Now, we had an Enchanted 2MT trial in the late 2022s, which said that you need not control the BP too intensively after an endovascular therapy. The reason being that you would be compromising on the cerebral perfusion, basically. You have to prevent ischemia. And this is the reason why the BP control after EVT shouldn't be too intensive. The BP targets were less than 120 and less than 140 in the 2 arms. So in 2023, we had 4 more trials that came up. 2 of these were published in 2023, and the last 2, Crisis 1 and Hope. These trials are completed, and their reports have been presented in the European Stroke Organization conference held in 2023, about to get published. So optimal BP, again, they said that intensive versus conventional in acute ischemic stroke, it may not be very, very helpful. So avoid doing an intensive BP control. Best to said low probability of benefit from lower systolic BP targets after EVT. Crisis 1 was to determine effectiveness of more intensive BP lowering target, the same as the previous 2. Hope was a little different. This Hope study, in the fact that blood pressure targets were according to the degree of recanalization obtained during the thrombectomy procedure. So if you see that they had a systolic BP target of 140 to 160 millimeters, if the recanalization was TC2B, that means if the recanalization was not perfect, not too good, you need to maintain a higher systolic BP as compared to patients who had a better recanalizations of TC2, C3, where you can go down to less than 140 with your systolic BP targets. So I think this is the way forward. You have to individualize your blood pressure control in patients post-EVT and not just have a blanket rule of a certain BP target in all the patients who come to you. Coming on quickly to the intracranial hemorrhage studies, and we have 2 major ones, the ENRICH, dealing with the surgical clot evacuation, and the neuro intensive care, a beautiful trial that came up, Interact 3. We'll be discussing both of these. So ENRICH was to evaluate the minimally invasive MIPS approach, actually. MIPS approaches, minimally invasive transsulcal parafascicular surgery for ICH removal using neuroimaging, basically. So previously we had the MISTI trials. See, Stitch 1 and Stitch 2 had come up. They did not prove any benefit of surgery over medical treatment overall. Then came the MISTI trials. MISTI trials said minimally invasive surgery along with installation of TPA might help you. So it became a level 2B evidence in the guidelines that came up in 2022. Now in 2023, we have a very nice trial that has been published. Actually, the report of this has been presented in the ESOC conference in 2023. The trial has been completed already. This was a multicentric, randomized, again, adaptive clinical trial. Inclusion criteria was adult patients, ICH volume between 30 to 80, GCA of 5 to 14. The trial results demonstrated a positive surgical outcome in the treatment of ICH. So what hope does it raise? It may be a promising therapy for improving patient outcomes, at least in supratentorial lobar ICH. So what the authors are looking at is a class 1 indication for a minimally invasive parafascicular surgery. Let's see how it goes in the future. Then we had this INTERACT-3 trial for the neurointensive care of patients with ICH. Till now, we were just talking about blood pressure reduction. INTERACT-3, a huge trial, around 7,000 patients taken from lower and income countries. And they said that it is not just the blood pressure reduction, but an overall intensive care bundle, a goal-directed care bundle protocol that helps you in decreasing morbidity and mortality associated with ICH. So what was this goal-directed care bundle? The two of them we already know. There has to be an early extensive lowering of the systolic blood pressures and reversal of anticoagulation. Along with that, we also have strict glucose control and antipyrexia treatment. So the target temperature should be less than 37.5 degrees Celsius in order to have better outcomes with ICH. Talking about aneurysmal SAH was quite significant this year because after an interval of almost 11 years came up the new guidelines. The previous guidelines that we had were in 2012. And now we have clinical guidelines published separately by the Neurocritical Care Society and another one by American Heart Association. So we have the guidelines from the NCS, Treasury et al., and these are the AHA guidelines, which are endorsed by pretty much all the societies. And what is the gist? I don't believe that there are too many practice-changing points that have come up, apart from the fact that they have discouraged the use of tranexamic acid in the first 72 hours, which was advocated in the previous guidelines. Apart from that, they say that there should be no specific BP target before aneurysm treatment. And that does not mean that you should not you should not treat accelerated hypertension. You should, but then there is no specific BP target before aneurysm treatment. There is no role of statins, endothelin receptor antagonists. This was there previously as well. And there is no role of antifibrinolytic therapy that I just told you. With regards to prevention and treatment of DCI, the NCS guidelines say that there is insufficient evidence, and the AHA guidelines say that there is a low class of recommendation and level of evidence for the augmentation of systolic blood pressure or cardiac output. So hypertension that we talk about, and intra-arterial vasodilatation. So there is a low level of evidence available for these. So the problem is there are not too many high quality studies available. And so they do not have sufficient evidence. Lack of benefit of anti-seizure medications beyond 7 days in patients with seizures. Oral nimodipine, avoidance of hypervolemia recommended. Well, these were present previously as well. One more study that came up was early drain, where they inserted a lumbar drain in patients with aneurysmal SAH, and they said it lessens the burden of secondary infarction and decreases the rate of unfavorable outcome. Underpowered study, but yes, food for thought. Let's see how things happen in the future. So more trials needed for this. Lastly, in stroke, TTM, regarding targeted temperature management, the NTCR recommendations published in BJA, and this was a huge group. We had the privilege of listening to Jonathan Rhodes from amongst the authors in our national conference SNCC this year at Agra. And these recommendations are basically to maintain a core temperature of 36 to 37.5 degrees Celsius, initiated within 1 hour of first fever identification, and maintain as long as the brain remains at risk of secondary injury. You obviously have to have a controlled rewarming, and shivering has to be monitored and managed to limit risk of secondary injury. The last part of my talk, I know I'm running out of time, is TBI. Quickly through this. Yes, there is the Center TBI. All of you would be aware of it. So this is the Collaborative European Neurotrauma Research this thing for TBI. So they have been doing a lot of research and work in TBI. Two important trials that came up were Rescue ASDH. So let me just talk about it. This was in NEJM. And what they did was they evaluated patients who were scheduled to undergo surgical clot evacuation for acute SDH. And they compared decompressive craniectomy against craniotomy. So replacing a bone flap or removing the bone flap was the idea. So 450 patients were enrolled, and they said that the disability and quality of life outcomes were similar with both the approaches. Although they also said that additional surgery may be needed twice as frequently in the craniotomy group, and there might be more wound complications in the craniotomy group. Similar findings were also reiterated by the observational cohort study from the Center TBI. And they said that there is no difference in functional outcomes in patients undergoing primary decompressive versus craniotomy. So the gist for this was primary decompressive craniotomy should be restricted to salvageable patients in whom immediate replacement of the bone flap is not possible due to intraoperative brain swelling. So if there is an intraoperative brain swelling, yes, you have to perform a decompressive, but otherwise, if you replace the bone flap as well, the outcomes are almost similar. So you may not necessarily perform a craniectomy for an acute SDH following TBI. This is my last trial. Medical interventions in TBI, till now a gloomy field. Nothing was showing any kind of benefit. This is the only trial till date that has shown some hope, and therefore I've quoted this. This was a large Chinese study who performed a right median nerve electrical stimulation for coma awakening, basically. So this was an RCT in patients with coma at 7 to 14 days after TBI. So in the right median nerve stimulation group, this stimulation was given for around 8 hours per day for 2 weeks. And they concluded that it's 6 months post-injury, a higher proportion of patients in the right median nerve stimulation group regained consciousness compared with the control group. An enlightening finding, actually. So maybe we have something possible, some optimism beyond the pharmaceutical and the surgical options that are available for us in TBI. However, we cannot say for sure a confirmatory trial is needed prior to implementation of this approach into clinical practice. The reason being it was an underpowered study, around 370 patients or so. Well, thank you so much. This was about the recent trials that had come up in 2023. Food for thought for all of you, and matter of discussion for our esteemed panelists thereafter. I request Dr. Ishu Goel to take over. Thank you so much for your patient listening.
Good afternoon, everybody. I'm Dr. Ishu. Thank you, Dr. Vasudha Singhal, for the wonderful summarization of all the developments that had happened in the last year. It was really very interesting to listen to them, and it was quite elaborative and at the same time very precise. So, ma'am, I just before I go on to the panelists, I just wanted to ask you what I would like to know about your experience with hyperbaric oxygen therapy for traumatic brain injury patients. Have you ever used it, or have you ever referred anybody
Ishu,
for
I'm
it?
sorry. The thing is, we do not have hyperbaric oxygen in Medanta
Anywhere,
here.
anywhere else, any other center that you know of that are
I
doing
heard it was
hyperbaric?
in Apollo, but how good the results have been, I have no idea, basically. I would not be the best person to comment on that.
All right, ma'am. Thank you so much once
How
again, and
about
thank
Kokila Bain and all? Are they doing hyperbaric for
here in JJ Hospital and in Godrej Hospital, I believe hyperbaric oxygen therapy is there. But then again, how many traumatic brain injury patients are being treated in this? That really I don't know. That's why it was a little intriguing for me to know about it, because it is another medical management that could be offered to traumatic brain injury patients if it is actually helpful.
Yeah, we need really, good trials, good quality trials to prove
Exactly, yeah.
it.
So randomized control trials are not there. On and off case reports are there,
Yes,
but they are inconclusive.
yep.
Yeah. I also thank the neurocritical care team for giving me the opportunity to interact with the best of the persons in this field. So I welcome the esteemed chairpersons for today, Dr. Arun B. Shah sir. He's the Director of Neurology in HN Reliance Foundation Hospital, and he is the pioneer in stroke medicine. And his efforts have made the stroke unit of Reliance Hospital one of the best in India. Welcome, Dr. Arun B. Shah sir. Dr. Joy Desai, sir, he is the senior consultant at Jaslok Hospital and Reliance Foundation Hospital, and he has more than 15 years of experience in neurology. His contributions towards sleep medicine have brought to our notice certain undiscovered aspects of neurology which are not very well recognized and not very well practiced. And he continues to amaze us with the intricacies of sleep medicine and makes us realize how much do we miss in our clinical practice actually. Then finally, I would also welcome Dr. Nishant Aditya sir, senior consultant neurointerventionist at HN Reliance Foundation Hospital. He has an extensive experience in the intervention field, and especially his results in mechanical thrombectomy dealing with the aneurysms are uh, totally undescribable. He is excellent in his work. And whenever we are referring any of our patient under his care, we are absolutely sure that the patient will have a good outcome. So welcome, Dr. Nishant Aditya, sir. So now, as Dr. Vasudha Singhal had summarized various developments moving from the tenecteplase to alteplase, shortening of the time for administration of intravenous thrombolytic therapy to a bolus using a tenecteplase, at the same time not increasing the risk of bleeding, and also the role of mechanical thrombectomy, where we are expanding our patient population by selecting a larger course as well as greater time windows, and giving the patients a benefit of improving the quality of life. I would like to ask Dr. Arun B. Shah, sir, that how in his vast experience has the stroke management evolved over the years, and what does he anticipate is going to happen in the future? What all more developments is he expecting in the coming future? Dr. Arun B. Shah, sir. So till the time Arun B. Shah sir joins us, Nishanta, this is sir, I would like to ask you that if you could please elaborate upon the advancements in the technology and devices used for endovascular therapies and their impact on patient outcome. Like, is it just the patient selection that has improved, or quality of diagnosis has improved, or is it also compounded by the fact that modern technologies and modern devices are coming up, which reduces the failure rate and which reduces the rate of complications to a certain limit? So, what, according to you, is the main player in this scenario, whether it is the patient selection or the treatment techniques that are increasingly favoring the outcome of the patients?
Thank you, Ishu, for introduction and invitation. Yeah, as you summarized all points in your question itself. So it is a combination of all the factors. When we started thrombectomy in 2009-10 with early penumbra devices, and when there was no trial, Mr. Clean came in 2013 and 14. All the challenges were absolutely paramount in getting the results, and results were not good in terms of recanalization, in terms of awareness in the emergency services. Neurocritical care was not up to the mark. In terms of not, they were not interested for the patient care. It just the knowledge, the idea was not there how to handle. Like the previous speaker has spoken about the blood pressure regimen, when to do craniotomy, when not to do craniotomy, what the now with large core thrombectomy, we have a special category where there is no hemorrhage, but there is a mass effect. All those knowledge came after 2013-14. All those 5 major trial came for mechanical thrombectomy. So as you were asking, it's a combination of factors. Like when emergency services were up, we always save time when triage happens very early. Even you must be aware, some of the hospitals you have seen or I go are having the triage system where it takes little more time. Our hospital takes minimum time because we are doing regularly mechanical thrombectomy. So it starts from here. Then mechanical thrombectomy, our own experience is increasing. Now low NHS trial is coming, less than 4. Although right now it is equivocal, there is the benefit versus best medical management is equal, but it will come sooner or not later to have a benefit when you do earlier thrombectomy. And their experience matters because when you do low NHS score, then you have to be good in getting the TK3 in 1 or maximum 2 passes, along with ICAD management and everything. Third, the third pillar is the ICU care, where patient is going to be there at least 24 hours and sometimes much longer than that. Some of the battle we lose in ICU because of the care level, no orientation about the neurocritical care system. We are fortunate to have a system in place where we are doing all these things, and that's why our results are getting better every single quarter of the year. And fourth is as a whole industry is growing. Now you must have heard about 088 aspiration catheter, which can go to middle cerebral artery, 8 French catheter going to middle cerebral artery. Now we are understanding the ICAD, coexistent ICAD, how to treat them, when not to treat them, can angioplasty suffice? So their industry, the delivery system is getting better, as facial system is getting better. So is all combining together. That's why our outcome is getting better. And now the real holy grail is the large core thrombectomy. When we don't have any precedence over that, when we do a large core thrombectomy, when patient is having edema, there is no data when to do craniotomy and when not to do craniotomy. ICH is different sound. I'm talking about large core vein which is getting edematous on day 2 or day 3. So those things we are learning is work in progress, and we will get some idea as a society, as a community, and we are getting better on all those 5 fronts, from the triage in the EMS, neurocare, intervention care, ICU, and as industry, neurointervention is growing. So these are very positive sign, and we are fortunate to be in this era. Issue back to you.
Yes, sir. Yes, sir. Sir, look, talking about all these large core infarcts that are coming up, the trials that are coming up in the last year, one thing that comes to my mind is that earlier when we were reading about the Dawn and diffusion trial, it was all about the penumbra that we were talking about. It was the core and the penumbra, the mismatch ratio should be high, and that was the indication when we went inside and the intervention was done. And even the other trial where the patient's symptomatology and the penumbra again, the salvageable tissue, the core and the symptoms were not matching. So we took it to be because of the penumbra. And again, to salvage the penumbra, we were going inside. So that time there was a lot of talking about the penumbra. But now the last trials that have come up in the last year are all talking about the core. And in fact, in the Tesla and the tension trial, they are just using the plain NCCTs and not even looking at the perfusion scan. So why this shift has happened, and like what are the reasons that this shift has happened, and what should be the actual approach? Should we look towards the perfusion scan, or is the CT enough to determine whether the patient is eligible for thrombectomy or not? Why this change happened suddenly from talking about to perfusion and just looking at the core size now?
Yeah. So you know that it all started with Angel trial, right? Angel and rescue.
Yes.
Then it went to select Tesla, tension, and the last one at the last, LASTE, where selection criteria was 0 to 2 aspect, is unbelievable.
Yes, sir.
So what happened earlier, our concept of core and penumbra was misplaced, if not wrong. There is a mini penumbra and mini core in all these core and penumbra area.
Yes, sir.
So what has happened then, when we achieved the down and diffuse on the terms of core and penumbra and the time, we went back to the sub data, that where we excluded and how patient did, and from there Angel study came. And then if you remember, the Angel study was aspect 3 to 5.
Yeah.
When the further trial, the last 2 trial, tension and the last came, it went to 0 to 3. Okay. And that's how it can be explained, that the mini penumbra and mini core is always there in the core and penumbra. So those tissue are not completely dead. That's why results of 0 to 2 MRS is significantly better than the BMT, best medical management, medical treatment, because there is a mini core and mini penumbra. And that's the explanation. We are getting reasonable, decent result in all those cases. Again, we have to be very prudent in selection, especially in India, where the healthcare system is different, because 40 to 50% patient will go dependent more than MRS 3 to 4. That's the only bottleneck for us. Otherwise, we are doing regularly now large core thrombectomies.
Yes, sir. So, but in all, like you said, that there will be a mini penumbra. So, but
Yeah.
the already non-salvageable tissue has already caused the damage, right? So, the weakness would already be there because of the involvement of that core. So, by salvaging that mini penumbra, what additional benefit are we looking for to go ahead? At the same time, taking the risk of complications of reperfusion injuries, hemorrhage happening in the large core. So, is it actually worth it to try and salvage the mini penumbra?
Yeah. So if you see the best medical management in 0 to 2 aspect, you must have seen the data of tension and last. In tension, only 2% patient will have the benefit in terms of 0 to 2 to 3 MRS, breast medical management, while the thrombectomy group is having 17% of MRS 0 to 2. Okay. Again, which patient will go to MRS 0 to 2 and which is going to be stuck at 3 to 4? Nobody can say. There is no way to say that. That's why number needed to treat. Although right now the large core thrombectomy group is so small that number needed to treat hasn't come. But it will come. It won't be 2.7 like acute stroke, but it will come because the mini penumbra and mini penumbra can grow to a larger penumbra and recover like the earlier days when we were not having any thrombectomy. What was our goal to do DSA? To see the collateral score? You must be aware of the collateral score, right?
Yes, sir. Yes, sir.
Earlier we used to do. And when the collateral was very good, we were not doing the intra-arterial TPA in those days. So at that time, we were calculating IV in intra-arterial TPA risk of hemorrhage versus good collateral. So we were taking good collateral as a safety point that it will salvage the penumbra. Okay. Same way, by opening a good blocked artery, achieving a TK3, those mini penumbra can get converted into larger penumbra and can help in the recovery. That's why the last trial had approximately 13% 0 to 2 MRS.
So even when the aspect score was 0 to 2?
0 to 2.
Yeah. Okay. So this is, I think this is the way forward that we're looking for in 2024, that even in the very, very low aspect score where we poorly prognosticate the patient, we should be a little hesitant while prognosticating the patient, since we are looking forward to many advancements in the interventional field.
Correct. Absolutely correct.
So, sir, Arun sir has joined us. Welcome, sir. Till the time we... good evening, sir.
Yeah, I can hear you.
Sir, welcome to the neurocritical care year in review. So we were discussing about the low aspect scores in the recent trials that had come up, the right. Tesla trial, tension trial, and the last trial. And it was very fascinating to listen from Dr. Nishant Aditya that in the last trial that is coming up, the aspect score is 0 to 2. And still in 17% of patients, the MRS scoring is also 0 to 2. So it was very fascinating to listen to that, and that gives us a hope in future that the prognostication of the patients would be better even if we try the endovascular therapy in patients with such a low aspect score. And I was also asking sir that suddenly the paradigm has changed from the perfusion mismatch, core to perfusion mismatch, to just looking at the large core infarcts. So I would quickly want to put up the same question to you too. What are your views that actually CT perfusion would now be required, or the only thing that we would require before going ahead for any of the interventions is just a plain CT scan? What do you think about it, sir?
I think this is a very important point. I think there is debate going on all over the world now, because the most of the workers would believe, and I personally would believe, that if you have a facility of CT perfusion, your accuracy improves and your unnecessary futile thrombectomy or also could be avoided.
So, sir, Joyce Sai, sir, I would like to ask you that we have talked about the neurocritical care. We have talked about various parameters that improve the patient outcome. We always keep on talking about the blood pressure, temperatures, glucose monitoring. But there's one thing that we never focus on, that is the circadian rhythm and the sleep disorders in patients who are in the ICUs. So this aspect is, I think, most often neglected. So I would request you to highlight the importance of circadian rhythm and sleep disorders in patients who are in who are suffering from neurocritical illnesses, especially the stroke patients, and how do they impact the ultimate outcome of the patient?
Yeah, that's a very valid question, Ishu. And the way to look at this is to understand the fundamental science of what's happening in human tissue. What is the implication of circadian rhythm? So what we do know today is that even at a cellular level, there is a circadian rhythmicity because of the presence of biological clock systems in every tissue. And from basic science research, what has been understood is that the cells are doing different things in the working hours, 16 hours of wakefulness, and the cells are doing different things when we are sleeping at night. Two cardinal things that emerged is that cellular autophagy, which is a cell repair phenomenon, both lysosomal and mitochondrial, tends to require nighttime sleep for it to occur. And at a cellular level, the timings are yoked to the daylight cycle because, as we understand conceptually, it is only we only conceptualize the brain as sleeping because it's visible. But even in cellular tissue, at nighttime when we are asleep, there is a biological quiescence with a repair process of a different kind. And this does not change when a person is critically ill. So in the ICU setting also, if circadian rhythmicity is maintained, if feeding time especially is curtailed in the hours when there should not be feeding, if intravenous and bodily access parameters are regulated to the 16 hours of our circadian daytime rhythm, it will allow tissue to function for what it is ordained by nature. Now, unfortunately, it's very difficult to do trials of this kind, but there are a few ICU trials that clearly demonstrate that melatoninization and behavioral intervention in the form of low light and restricted intervention between 12 o'clock and 5 o'clock in the morning improves recovery paradigms as measured by uh, any of the recovery paradigms for a critically ill person, including their immunological response and tissue responsiveness. So this is going to be the frontier. The more we understand circadian rhythmicity, then it has to enlighten us in the way we look at physiology in the ICU. Uh, when we talk about you heard the previous 15 minutes of very cogent discussion on trials. Because we have set up a scientific system which is based on trials. To mount trials of this kind in an ICU will require some stringent doing and a lot of discipline and enthusiasm. And I'm hoping that across ICUs in the hospitals that we see and globally too, people take up this baton. And my own perception is that the reason why we are not thinking like this is because the sleep neuroscientists are not talking to clinicians. Someone has to bridge that gap.
Exactly,
And
sir.
I have no qualms in being one such person, but it's just not enough. We need a lot of clinicians to understand applied physiology when we know the science, and then in a critical illness to apply that physiology.
Right, sir. I think that is one thing we should always keep in mind while monitoring all the other things, because like all the patients always keep on complaining that we are not able to sleep, we are not able to sleep. We are managing the hypertension, but we are not addressing the cause of hypertension because it is the lack of sleep that is causing the hypertension to happen at night, the blood pressure to spike up at
One of
night.
the biggest challenges is the interventions that we do in terms of bodily orifices, the presence of tubes, the presence of
Right.
endotracheal and catheters and intravenous large bore accesses. They will certainly impede the natural process of sleep acquisition and tissue quiescence. So somewhere I think if intensive care specialists are to talk to physicians and physicians need to be more proactive, we need to think, can we cut down a bodily invasion and procedural input into the body for that window of time between 12 and 5
Very
of
true, sir.
local time,
Yeah,
from midnight to 5 in the morning?
right, sir. So, I would request Arun Shah sir to continue. He was addressing us on the validity of CT perfusion, and at the same time, I would also request him to please guide us on what should be and what can be the appropriate time when we start anticoagulation in a patient with large core infarct, because that's always a dilemma. Many of our patients have concomitant atrial fibrillation happening. They are prone to pulmonary thromboembolism, or they have a history of prior pulmonary thromboembolism, and it seems that we are dealing with a double-edged sword. If we don't give them, they may suffer with another cardioembolic stroke or thromboembolism anywhere else in the body. And if we give anticoagulation prematurely, then they may bleed. So what should be the exact time where we should introduce anticoagulation in such patients?
Thank you, Dr. Ish. I think the point we were just about the perfusion scan. I think perfusion scan, if given a facility, I think is always preferable because you can become more accurate and more scientific. And as far as this large core business, I have the thing is, if you see the last attention study data, the difference between the treated, thrombectomy, I mean, acute treated with thrombectomy versus those who were not treated, the obviously modified Rankin was possible, better, that is three or so, three or less, was in about 31% of patients in the treated group and about 13% in the non-treated group. So even if you look at those data, there is still about 6 out of 10 patients who were still disabled or dead.
Yes.
So by using even in the treated group. So I
Right.
think we'll have to take those data very carefully and select your patients if you have less comorbidity, who are a little younger, and if they have a large score, maybe I would take the cut. So it has to be individualized. I don't think we can apply that rule of 3 to 5 aspect to everyone. I
Right.
think that is why in this situation, if you have further information from the perfusion scanning, it will, your decision will be more accurate. So I would still think that despite these three trials which are used only the plain CT, I think the perfusion scan will help, particularly in selecting a patient better, in order to reduce the number of patients with a bad outcome. So ultimately, you don't want the community having people with bad outcome, aphasic, densely hemiplegic. You don't want to have that kind of survival. So I think, in my opinion, perfusion scan still has a role to make sure, and then not only that, the recent, I think the data has shown that your accuracy will definitely improves by using perfusion scan.
So that's a very valid point that we should always
Only,
keep in mind.
only point is the time factor. You know that I think the people who talk about only plain CT scan, I think you are saving time. So if time is vital, probably sometimes, particularly in centers where you have to ship the patient from one place to other for mechanical thrombectomy, on in those centers, maybe plain CT scan itself is good enough so that you are saving time. But wherever bigger centers where the facilities are available, it is always better to have perfusion scan to improve your decision making, and you reduce the number of survival in a modified Aitken 4 and 5.
Yes, sir. So,
Yeah.
so
And as
we
far as the population is concerned, I think the now recent trials have shown that starting early NOAC in people with ischemic stroke is definitely possible. It has to be again individualized, number of hemorrhagic conversion, mass effect, size, all those factors have to be kept in mind. But if you start early, it is safer nowadays in people with atrial fibrillation, and it has good outcome compared to delayed, the last study which has already shown that.
Yes, sir.
Yeah.
So, a quick question to Nishant Aditya, sir. We have been talking about all the studies are primarily focused on the anterior circulation strokes, large core infarcts. Everything is pertaining to the anterior circulation. But I wanted to ask Nishant Aditya, sir, that what do you think are the indications for endovascular therapy in large core infarcts and posterior circulation strokes? So, is it possible to do some intervention even with a large core infarct in the posterior circulation? And what is the definition of a large core infarct if we are talking about the posterior circulation? Have we made any advancements even in this particular area?
So, as you raised the question, we know that posterior circulation is right now like often, nobody takes it like anterior circulation did. However, basic trial has come for the bacterial thrombectomy. Uh, Large core definition of posterior circulation is completely different song because we are dealing with two different kind of tissue. One is the brainstem, which is very mature, like spinal cord, and other tissue, the cerebellum, is a very new tissue. Is like a middle cerebral artery or anterior cerebral artery. So there, the large core definition is still not completely streamlined. However, knowing the by the perfusion scan, as you know that we are using rapid, so we get some data for the posterior circulation also while we do it. So large core, we are doing always large core if that large core is not involving the pons. One or two slices of complete pons whiteness opening the basilar artery is not going to help at all, because whatever you do, all those consolidated tracts are gone. So that criteria still remain the same. The outcome in those patients are low, if not abysmally low. However, the large core infarction, when we see on the cerebellum, is not a criteria to exclude the patient from thrombectomy, because we know even it get edematous, we can do easily the posterior fossa discompression, and those tissue can be salvaged still post ischemic changes in the cerebellum. So as of now, for posterior circulation, if PONS is not showing complete white signals on MRI, then we still go for the thrombectomy regardless of the time and regardless of the quantity of infarction in cerebellum.
Okay, sir. Right, sir. But the rate of complications are much more in the posterior circulation, I believe, as compared to the anterior circulation. That makes us more hesitant.
No, it's not complication. Stuck patients are more in posterior circulation.
Right.
The locked in patients.
Yes, sir. Yes, sir. Yes, sir.
Yeah.
Understood, sir. So I had many more questions to ask from all the three esteemed chairpersons, but I would, since we have already exceeded the time, I would just put up a quick question to Joy Desai, sir, and end this neurocritical care year in review. But there is a very hot and upcoming topic of artificial intelligence. Artificial intelligence is everywhere around us, and I would like him to enlighten us on the fact that what can be the possible role of artificial intelligence in neurocritical care, and if at all it is going to be helpful to us, then what are the roadblocks that because of which till now artificial intelligence has not been inculcated in our critical care system. Joy, sir?
Let me get into a zone where I can speak to you. Am I audible now?
Yes, sir.
Yeah. See, this artificial intelligence thing has become the buzzword, and we all know that if you want to whittle it down to the bare bones, AI is nothing but amalgamation of various data sets to produce an algorithm which is applicable in a given clinical setting for a given clinical problem with numerous variables. So unlike the perception or the anticipation is, the conceptualization is that there may be some aspects that a human, as experienced as a senior neurologist, may not be able to factor in when analyzing a patient, and therefore an algorithm works. So far, most of the algorithms that have come up have been for diagnostic purposes, for volume calculation, in strokes, for pattern recognition in, say, recognizing early tumors in non-neurological settings and in neurological settings. So for us to anticipate where we will go is difficult. At this juncture, I think it still makes sense for an experienced clinician to take in an astute history in as short a time as possible in promulgating a treatment plan in the very quick setting of a stroke where the clock is ticking, and we know that as we analyze the amount of time left for an intervention that can result in a reperfusion is small. How algorithms are going to develop in future is an imponderable. Right now, the algorithms only integrate data sets for diagnostic patterns. I'm not sure that we are at an age where we can translate this into better therapy. And I'm happy to listen to Dr. Arun Shah as to what he thinks. I think we are still far away from that.
Yes, sir.
Is Sir here or has he left?
Yeah, Joy, I think I probably my understanding of this subject is still far away, I think. So I may just say that in future it will be. Right now, I think the human computer is better in the bedside situation than the AI. Of course, ultimately AI, the result will depend on how you feed it, you feed the data. So
Absolutely.
after all, human brain which will fit the data properly, then will probably be superior than our brain. That's probably I don't know whether we'll look at that day in our lifetime.
Yeah. So
I'm sure
currently
you'll.
the excitement in AI is from
Ah,
diagnostic algorithms. So pattern
correct.
recognition in diagnostic tools.
Right. Yes,
And
sir.
that's
I,
certainly galloping at a quick pace.
correct. Eye movement analysis also, I think there are a lot of softwares available for that in AI. So, but
Yeah.
that doesn't give us analysis as such. It just gives you analysis, right?
So again, it's pattern recognition. So again, since we recognize patterns, and a lot of neurology is pattern recognition, clinical imaging, investigative input, and that pattern tells us what the underlying mechanistic process is biologically. So we are still
Correct.
there. So I
So,
think in time, therapeutics may change, but for now, it's going to be diagnostic pattern recognition.
Yes, sir.
Dr.
right.
Joy,
So, in
can
fact,
I just intervene
yeah,
a little bit? Although I'm a
yeah.
nephrologist, I'm Dr. Sudhir Das.
Yeah, hi.
Joy, hi. Arun sir, just allow me to just elaborate on something about the AI, since I had a certificate course on AI in digital
Oh,
health.
great, great,
Wow.
great.
Yeah.
Super.
So basically, what you are talking about diagnostic is quite advanced right now. They are also utilizing the vision also right now.
Yes. Yes.
Okay, with the neuro visual like small cameras and other things they are integrating. And the basic is basically it is a two types of thing they want to pursue. One is supervised learning, the other one is unsupervised learning. What is supervised? Supervised is basically you have to have database and you have to label them. That let us say the example is that this is a benign tumor, this is a malignant tumor, and you give the data into the computer the database of thousands of benign and thousands of malignant tumors, and then subsequently that will understand, that is called a strain model, where the training to the computer or the software will be done, and afterwards it will understand that this is the difference between the two by different algorithm. Like the Bayesian algorithm is one, where they do distinction between the any tumor, benign or malignant kind of thing. Then if you throw any image of something like CT scan or something, or any of the histopathology images, then it can distinguish between a benign and a malignant tumor, but still there is a fallacy to it. It will just give you an idea that this has to be analyzed faster than the others. If it is a malignant tumor, then obviously it will pop up in the screen that yes, this person needs urgent attention. That is what. What is unsupervised learning is basically it is like a robot. So it is basically when you do some mistakes, you will be getting a feedback loop, and that will tell us that no, you have to be punished. So if the feedback tool says that no, whatever you have identified is wrong, then it is a punishment for them. So there you will not label the picture or any other things like the robot does. The likewise, it will understand by itself that punishment is repeatedly. I'm making a mistake, like a child when you telling the child that it is wrong, this is right. Likewise, so this is the two ways, supervised and unsupervised learning, they are much more inclined towards. And this probably at this moment is in a nascent stage. I think still our brain is much more smarter than them, than the computer, but
Yeah.
analyzing capability is phenomenal.
Yes.
But
No,
as
no, there
I
is already
said,
an algorithm in place for drug-drug interactions. So when you prescribe a medication and there is already data fed in that the patient is on these drugs, there's a pop-up which says that this drug will interact with XYZ. So yes, we are getting there slowly, but like I said, I think the crux of the matter is pattern recognition. And therapeutics is some far away, so human brains are still going to be needed for the next decade. at least.
No, Joy, that's what I think, Joy. What you said is correct. You have some pattern, and probably it will tell us what are the rare possibilities, which sometimes doesn't come to our mind. Maybe that is the
Yeah,
way it may work out.
yeah. Okay, wonderful. I think we had a wonderful evening
You
today.
also, the Dr. Ishu, you did not discuss the most important advance which has occurred is the in the intracellular hemorrhage. First time it has
Yes,
shown
sir.
that surgery helps. That is a
Yes, sir.
very important advance in my understanding of this
Yes.
year.
Dr.
Up till
Vasudha,
now,
yes, sir. She,
up
yes,
till now, we always thought surgical trials of ICH were always negative. And first time we have a trial that if you do this minimally invasive surgery within the first
yes,
24 hours, you can improve the outcome. And that is the most important advance as I see it. And there's a lot of future in the next year or two.
yes, sir. In this aspect also, sir, I just wanted to ask that here they had excluded the thalamic hemorrhages, and they had taken only those hemorrhages where the cause of the hemorrhage was not very clear, like where the cause was not known actually, some structural lesion or something in aneurysmal bleeds or all
Correct.
those kind of symptomatic bleeds. The causative bleeds they had ruled out, and also the thalamic hemorrhages. So what I thought is
Correct.
that because they had excluded the thalamic hemorrhages, and most of the hemorrhages that we come across, hypertensive hemorrhages, are localized around the deep areas of the brain. So it would be good to see another study which extrapolated its effects to such areas as well.
Correct. So
But as you
that
said,
device, that device study will probably tell us that.
yes, sir.
Right now, this enriched study did not use that device. The
Yes,
other study which is going on is with that device, which will
yes,
probably go to the deep lesions also.
yes, sir. So I think this is the way ahead in 2024. We should definitely come
Correct.
across these studies, sir.
So we'll probably, I almost change my mind. So if you have probably try to operate ICH within 24 hours, if you think that is going to give you problem in the next few days, rather than wait for the third day or fourth day, you know. And
Yes,
we
sir.
saw just example that the improvement definitely ultimately outcome was better in a person who was operated within hours, you know.
Yes, sir. Sir. So I end this wonderful evening and the session by thanking all the chairpersons and the presenter, Dr. Vasudha, once again for taking out their time and discussing such nice topics with us. And over to you, Dr. Aringam, sir.